It actually started because of the rural areas of the county where EMS response was probably the longest to respond because it takes longer to arrive on scene. And we were really struggling with connecting patients to care, especially those who were declining hospitalization or being transported to hospital. Thanks to that consortium and thanks to this funding opportunity, a lot of services have been able to get lifted off the ground, not necessarily all paid for by the RCORP dollars, but were able to happen because of the RCORP support. We are the first state in the nation that established an overdose system of care. We now have a statewide EMS induction on low threshold buprenorphine program. And so all of our patients that are revived with Narcan post overdose are offered a induction. If they qualify based on their scores, they are offered low dose buprenorphine induction right in the field. So if they do not want to be transported to the hospital, we have EMS who is now able to leave them with buprenorphine, and they are able to start their treatment right then and there at the point of revival. And it started in the rural area. It is now a statewide program. We are super proud of this. We do have some work focusing on access to information and access to services that are for non-English speakers. In Delaware, we have two fairly prominent populations in our rural areas. It's the Spanish-speaking population, but we also have Haitian Creole. We have printed flyers in various languages to target that population. We have a couple farms and poultry plants that employ large amounts of migrant population, so we target our outreach with these materials to those workers. In one of our rural communities, we have a social worker who is part of the police department, who doesn't ride along with the police. He's behind at the police station and is available to respond to a scene of accident. That social worker, using his training and his knowledge, is able to check whether that client is connected to treatment somewhere else already, and is able to reach out to the treatment provider to coordinate. And if that person doesn't have any connected treatment episode or anything like that, then he's able to brainstorm of, is he insured, uninsured, underinsured, does he need state-funded services, does he need inpatient, outpatient, and then connects them to appropriate services that way. He does a lot of the work from the police department central office and helps the police officers deal with individuals who have either mental health issues or substance abuse issues. The other police department has more of a drive along where they are seeing majority of their cases, Friday night, Saturday night, that are either overdoses or mental health issues. Because it's a smaller community, that individual can go with the trooper that's riding along and responding to incidences. So each of the police departments chose a slightly different model that they wanted to adapt in their communities. So we have really connected a lot of these resources together and worked with each of the police agencies to develop a program that was best suited for them.